So, oral medicine exam year 5. The general approach involves gathering information. That's the history of the patient, the medical history, the social history, the dental history, the family history, any test results or current investigations by other specialities, okay? And of course, extra and intraoral examination. Most of these things will be already given to you, okay? So do take advantage of what you have in your hands. The exam skill set being tested throughout the whole of the Viva, it can be categorized in these 4 categories. So recalling information, what your knowledge about the condition, the specific condition or the differential diagnosis of the condition is, what is your understanding about it, and whether you can present clinical reasoning in respect to the condition you have in your hands. So basically what we're looking for is to see whether you can graduate and go out in a general dental practice and be a dentist, okay? As simple as that. Our focus, so what are we looking for? In all oral med vivas, you will need to describe the lesion, okay? A lot of the details are already given to you. So if you have a referral in your hands, or if you have a Viva as I sent it out to you, most of the things that you need to describe the lesion are already stated there. So you only have to recall them, okay? Then we usually proceed with differential diagnosis. Differential diagnosis is probably the most difficult part because you need to recall conditions that look alike and try and reason which is the most likely diagnosis, okay? And you have to justify your choice. So that's the most difficult part. That's the clinical knowledge application part of the exam, okay? When you're asked to give a differential diagnosis, name at least 3 different conditions that come to mind, okay? If you name 3, if you just give the name, you will get a pass. We will see, I have a breakdown of these questions later on to see what, when we do discuss the Viva, to see what more you need to say to get to achieve an honors and what more you need to say to achieve a distinction, for example. When you come to most likely diagnosis, you need to think of horses, not of zebras, okay? So you need to think of what is the most common condition that looks like the one you have in the photos, all right? Think of zebras only when you are game of words, all right? It means that there might be that you have your most likely diagnosis is not one of the most common, let's say, as in your Viva, you have a white lesion. It's not the most common white lesion that you can encounter in the mouth, but it might be very specific to location, shape, size, and other characteristics. So that puts you in the savannah to think the less likely diagnosis of the differential diagnosis. Management, think of the patient as a person. Do not just see the lesion and nothing more behind the lesion. Think of the patient holistically. Always consider further investigations. They could be blood tests, they could be x-rays, they could be biopsy, whatever you need to conclude your diagnosis. They could be prescribing medication, that's how you manage the patient. That depends on the case. And of course, no important guidelines. Nice guidelines are the ones that we use in the UK, so we have to abide to those as much as possible. Always bear in mind, guidelines are guidelines, okay? They're not the gospel. So you have to follow them as long as there is clinical reason. All of the guidelines give you some kind of flexibility and rely on your clinical judgment to decide what applies in each case. So let's start by the first part. Describe the lesion. What do we mean by that? What do you see? The lesions that you will see in the mouth can be grouped in 3 different categories. Loss of surface, so it could be an erosion, an ulcer, necrosis, depopulation if we have loss of surface on the tongue, atrophy. They can all be called an ulcer if you like. Loss of surface, if you call them an ulcer, everybody would be happy with that. Gain of surface, so a swelling of any shape or a hyperplasia. You can use other terms. You can call it a mass, you can call it a tumor. Tumor is not cancer, okay? So it's just a swelling, basically. You can call it a growth. You can call it, if you want to be really posh, an exophytic lesion, okay? And then the third main category is the change of color. So if we have change of color without significant loss or gain of surface, it means that our primary lesion falls into one of those categories. So it can be white, red, blue, purple, brown, gray, black, occasionally yellow, okay, or yellowish. This usually falls under the white, but do not forget combinations, okay? So you can have a white and red lesion, all right? The most common combination when it comes to color, and you can have a swelling that is actually ulcerated, as with many cancers. You have to state the primary lesion. So the primary lesion in an ulcerated tumor is the swelling. The primary lesion in a non-homogeneous leukoplakia, which is white and red, is a leukoplakia, so it is a white lesion, all right? So when you need to describe, when you'll be asked, prompt to describe the lesion, the first thing you have to state is what you see. I see an ulcer, I see multiple ulcers, I see a red and white lesion, I see, just as simple as that, okay? You don't need to do more than that, and then take it step by step. Ask yourself, where is it? Is it on the lips? Is it upper, lower, near the vermilion border? Is it on the buccal mucosa? Where on the buccal mucosa? Behind the commissure, anterior, middle, posterior third. You can state where it sits in relation to the occlusal plane. Is it on the tongue, again, dorsal or ventral surface, lateral borders, and again, which third of the tongue is it on? Palate, hard or soft, gingival, free or attached, and other areas like retromoral area, uvula, tonsils, oropharynx. You need to state whether it is on the left or the right-hand side, or whether it sits on the midline or it sits on one side but extends over the midline, okay? You can give a position relative to a tooth. Let's say you have a traumatic ulcer on the tongue, and you can say that it's on the left-hand side lateral border of the tongue, opposite to lower left 6, for example. That's a very accurate description of location, okay? Other details that you need to give. Size. A rough size. We don't, you have a photograph in your hands. No one expects you to have a ruler, take it out and measure it, okay? But for example, if you have, let's say, an epilis that extends over both premolars, epilis is at least 2.5 centimeters in diameter. It cannot be smaller than that. You cannot say that it looks like it's half a centimeter, okay? So give the size. You have to state whether the lesion is single or multiple, unilateral or bilateral. Roughly, if it has a shape, so is it like a sphere? Is it triangular? Is it rhomboid? If you can define a shape, is it elongated? Whatever it is. Describe the surface texture and the color of the surface. So besides the colored or pigmented lesions that already the primary lesion group is determining a color, most of the other lesions will have some color alteration. So ulcers quite often will have an erythematous either base or an erythematous halo, so an erythematous ring around them, okay, a red ring around them. You can have like bluish color on the swelling, so you have to describe that as well. If you have a swelling, we need to know whether it's sessile or pedunculated, okay? Sessile means that the base of the swelling, the way the swelling arises from the tissues, is wider than the rest of it. Pedunculated means that there is a neck connecting the swelling to the underlying tissues. If it is an ulcer, we need to know about the base and the edge, so the margins of the ulcer, whether they're rolled up margins or anything like that. Very, very important to include palpation. So we need to know whether the lesion is soft, firm, or indurated. If there is pain or other symptoms like temperature, lymphadenopathy, anything else, and time and change. So how long has the lesion been present and has it changed in any way? Most of this information will be given to you prior to your exam. So use it, okay? You do need to state the type of lesion to get a pass. So if you start describing a lesion to me and say, well, we have a lesion on the lateral border of the tongue, so-and-so size, so-and-so shape, it looks red, it looks white, but you don't state that this is an ulcer, okay? you won't get a pass. You do need to say this is in, you need to understand what it is. So basically give as much detail as possible by the information you were already given and by what you can see on the photos. So moving on to differential and most likely diagnosis. When you approach a differential diagnosis of a lesion, that's usually the most difficult part, okay? You cannot recite a whole oral medicine book. No one can, all right? I cannot. So think of the anatomy and the histology. What tissues do we have in the area? We have epithelium, connective tissue, minor salivary glands, teeth and the dental apparatus, muscles, nerves, vessels, bones, adipose tissue, other tissue like melanocytes. It could be foreign bodies, it could be metastatic disease, okay? So any of these can give rise to a lesion, to the lesion that you're actually seeing. So if we break it down and try and see what is a main differential diagnosis for ulcers, all right? My personal preference is to kind of group them in single or multiple because I find that easier to remember. There is a way of grouping them as primary or secondary. And what do I mean by that? Primary are ulcers that are not preceded by vesicles. Secondary are ulcers that are preceded by vesicles. So the disease will firstly come as a vesicle that will break and leave an ulcer behind, okay? I've prepared slides for both, so you can refer to both and pick the one that is more convenient for you to learn and remember, basically. So, single ulcer. The most common reason for a single ulcer in the mouth is trauma, okay? So I've put everything, and that will apply to all my slides, according to what is the most likely reason, most likely cause, all right? So differential diagnosis in the way of we go from the statistically highest incident to the less likely diagnosis at the bottom of the slide, okay? That's why the different colors and everything. So trauma in the oral cavity can be chronic or acute. TAGSI is falls under the category of trauma, but also forms an entity itself. TAGSI is an acronym for traumatic ulcerative granuloma with stromal eosinophilia. Easier to say eosinophilic granuloma. That is not as common. I've just included it there because it is traumatic. It is initiated by trauma, okay? But that would be about, I would say, below infection, all right? Or the same statistically, the same statistic incident between 4 and 5, somewhere in there, if we would examine it separately. So burns can be chemical or thermal. They fall under the category of trauma. And don't forget to necrosis. So when you give an LA, sometimes because of the vasoconstrictor factors in the LA, you can see a little bit of an ulcer forming at the area a couple of days later, and the patient is saying, oh, it still hurts me, and that's necrosis of the tissue on the area of the anesthetic administration. Major aphthy can present as a single ulcer in the mouth, okay? Sometimes it can be more than 2 or 3, but quite often it's just the one. Oral cancer, of course, do never forget cancer, okay? It can be drug-induced. Drugs like the likes of nicorandil can induce a single ulcer, especially on the tongue. Infections, bacterial infections like tuberculosis and primary syphilis. Primary syphilis looks very much like a major aphthy in the mouth. It heals spontaneously. TB is not that common in the UK, but syphilis is on the rise. And people with primary syphilis usually are unaware that they have contracted the disease. And because it heals spontaneously a few weeks later, they usually go about by spreading the disease because they're still contagious themselves, but they don't know that they have it, okay? And then before the secondary syphilis develops. It could be fungal, much more rare, of course, like histoplasmosis and blastomycosis. They can cause single ulcers, especially on the tongue. Necrotizing ciliometaplasia, usually that is on the posterior third of the buccal mucosa near the retromolar area, quite a rare condition. Allergic reactions like contact stomatitis, especially to foodstuff and sometimes to toothpaste and mouthwashes. Usually in that case, the old ulcers are multiple, but very rarely they can be single. And there are two conditions extremely rare: midline lethal granuloma, which is a type of lymphoma that can appear on the palate, which is a very severe form of ANUG that can be quite destructive. I don't think you can see that in the UK, but areas that there is a lot of malnutrition, very poor hygiene conditions, it still exists, unfortunately. So if we move on to multiple ulcers, okay, so conditions that appear with multiple ulcers can be subdivided to acute and chronic. So what I mean by that is that there is short duration and sudden onset of the appearing ulcers. So RAS being the king of this group, okay, so recurrent after stomatitis, minor, major, or herpetiform, and the minor after ulcers obviously being the most common of the three. Most of the viral infections that affect the oral cavity present as aphthous-like ulcers, so as multiple small ulcers, including recurrent herpes labialis, primary herpetic gingivostomatitis, recurrent intraoral herpes simplex infection, which is the same virus that causes recurrent herpes labialis. It just affects usually the palate rather than the lip. It's more rare, of course, than herpes labialis. Herpangina, that's a Coxsackie virus. Varicella zoster, both primary and secondary, so both chickenpox and shingles can present as multiple ulceration in the mouth. Again, herpes family of viruses. And hand, foot, mouth disease, that is a Coxsackie virus again. Most of them, besides the zoster and the herpes labialis, and obviously the recurrent intraoral, so the latent infection of herpes, and are seen usually in adults. Most of the other ones are usually seen in childhood. Saying that, you cannot exclude that an adult can have herpangina, okay? Erythema multiforme, again, is a condition that can present with multiple ulceration. It can be even, sometimes it used to be the same, we used to call erythema multiforme gravis, the Stevens-Johnson syndrome, but now they are considered two separate conditions because of causative factors. Allergic reactions can present as multiple ulcers. Bacterial infections like ANUG, anus, which is the same bacterial infection affecting the gingiva only, affecting deeper periodontal tissues, or affecting and spreading to the rest of the mucosa. So in that case, it's called stomatitis rather than gingivitis or periodontitis. And of course, Behçet syndrome, that looks exactly like recurrent after stomatitis, but it also affects genitalia and a lot of other systems on the body, and it is extremely rare in the UK. More common in Greece and Turkey. So Eastern Mediterranean is more common for Behçet syndrome. Now we see ulcers with chronic duration. Kings like oral lichen planus and mucous membrane pemphigoid, okay? So the ulcerative or erosive, whatever you want to call it, lichen planus type, the mucous membrane pemphigoid, followed by lupus erythematosus, then pemphigus vulgaris, inflammatory bowel disease like Crohn's disease and ulcerative colitis. When we see the ulcers in the mouth, it used to be called, especially in the USA, they call it piostomatitis vegetans, okay? Granulomatous disease, other than the Crohn's, like sarcoidosis, vaginous granulomatosis, and orofacial granulomatosis can present with multiple ulcers. Usually in those cases, we will have some kind of swelling somewhere as well, so it's not going to be ulcers alone. And other immunological diseases like epidermolysis bullosa acquisita, angina bullosa hemorrhagica, linear IgA disease, dermatitis herpetiformis, which is related to celiac disease, they're much more rare conditions. And I forgot to include drug-induced multiple ulcerations there. I'm very sorry. They should be somewhere between 5 and 6, okay? Drugs like methotrexate, usually they can cause aphthous like ulcers. If now you want to follow the different categorizing, so primary and secondary, what falls under primary is trauma, infection, recurrent oral ulcerations, immunological or inflammatory disease like lupus erythematosus and lichen planus, hypersensitivity reactions, drug-induced and neoplasia. And what falls under secondary is infection, especially with herpes viruses, and immunological diseases, specifically vesiculobullous diseases like pemphigus and pemphigoid, erythema multiforme, and the rest of them that are more rare. If we now look at the differential diagnosis of swellings, I find that maybe the most complicated one, because if we really want to be very precise, it's vast. It's a swelling, it can be anything, okay? So because we cannot go by that, you cannot go to exam and say, oh, it can be anything, okay? I tried to categorize. I give you a slide with all, like a summary of all possible swellings in the oral cavity, okay? I'm not going to read through it. There is no point. You will have it in the end. But what I have done then is I tried to categorize swellings by anatomical site. So following this categorization, lower lip, upper lip, buccal mucosa, gingiva, localized or generalized, floor of the mouth, tongue, hard or soft palate, and then multiple swellings rather than single, and neck masses. What I'm going to give you is what is the most likely swelling to appear at each site, okay? And then followed by a differential diagnosis. So swelling on the lower lip, the highest chances is that it's a mucocele, all right? We have two types of mucocele, extravasation, mucus retention. It doesn't matter if you don't state them both and you just say mucocele, everybody will be happy with that. It's followed by fibroepithelial polyp, squamous cell carcinoma, other mesenchymal tumors such as hemangioma, neurofibroma, and lipoma, salivary gland tumor, and keratoacanthoma, a much, much rarer condition. If we now see the upper lip, that's a bit different to the lower lip, okay? So the most likely swelling to appear on upper lip is a fibroepithelial polyp, followed by salivary gland tumor, okay? So be really vigilant and alert if you see a swelling of the upper lip, especially one that looks like a mucocele, because quite often the salivary gland, minor salivary gland tumors on the upper lip have very many common features to a mucocele, okay? So mucocele actually, statistically, comes after the salivary gland tumor, and then other mesenchymal tumors follow, and nasolabial cyst, do not forget, near the midline. When we're talking about salivary gland tumors, here I've just named a few, okay? So it could be a benign or a malignant tumor. The most common of the benign ones is the pleomorphic adenoma, and the most common of the malignant ones is the mucoepidermoid carcinoma. So these are the names that you need to keep, okay? As I said, you not have to learn all the names, but these two, if your Viva is anywhere near that topic, you will have to remember. So if we go to swellings of buccal mucosa, again, fibroepithelial polyp by far the most common, followed by lipoma, mucocele, hyperplastic lymph node, other mesenchymal tumors, squamous cell carcinoma, and salivary gland tumor, minor salivary gland tumor, comes last here. The tongue, again, fibroepithelial polyp. Some people call it fibroma. It's the same entity, okay? As you will see, that's probably the most common swelling in the mouth by far. Followed by squamous cell carcinoma, mucocele, other mesenchymal tumors, pyogenic granulomas, and lingual thyroid, okay? That's a quite rare swelling of the tongue, and it's always located at the root of the tongue, as we call it, so the very, very posterior third, and it's just embryonic remains. Sometimes the thyroid during the embryonic period doesn't descend to its place. And if we have such a finding, we need to know whether we actually have a thyroid in the right place before we decide to move it, because it might be the only thyroid tissue in the body. Okay, so it is rare, but it is quite important to know what it is. So if we see a swelling of the gingiva and it's localized rather than generalized, so it's mostly singular, the most common one is a fistula, so a draining sinus, okay? Followed by epulis fissuratum. That is only for people that have dentures, because it cannot be caused without a denture. Followed by pyogenic granuloma, peripheral ossifying fibroma, peripheral giant cell granuloma, and fibroepithelial polyp. All the conditions on the right-hand side of the screen, over there where my cursor is, they can present as swellings of the gingiva. So squamous cell carcinoma, metastatic tumors, gingival cyst of the adult, traumatic neuroma, Kaposi's sarcoma, peripheral odontogenic tumor, genital epulis, melanotic neuroectodermal tumor of infancy, and other mesenchymal tumors, but they're extremely rare. If we now look at gingival enlargement as generalized, the most common reason by far is plaque-induced gingivitis or chronic hyperplastic gingivitis. When I was taught, that's what we called it, okay? You're going to be sick of it for the rest of your professional lives, day in, day out, you're going to see it. Saying that, it is followed by drug-induced gingival hyperplasia, which is usually fibrous. So in contrast to the plaque-induced, you don't always have the erythema, the bleeding, the signs of inflammation. So drug-induced gingival hyperplasia, certain drugs like nifedipine, for example, can cause it, is followed by gingival fibromatosis. That's a hereditary condition, looks very much like the drug-induced gingival hyperplasia, but there is a genetic background to that. Leukemic infiltrate. So if you have a gingivitis that doesn't look quite right to you, you tried everything, you've done your debridement, the patient has followed oral hygiene instructions and is maintaining a good level of oral health, but is not responding to treatment, basically, do have like a full blood count of the patient. It's just a full blood count just to exclude a possible leukemia. It is rare, but sometimes, especially in adolescents, it can start, it can be diagnosed, and the first presentation can be the gingivitis. Another generalized swelling of the gingiva presents with Wegener's granulomatosis. It's called strawberry gingivitis, and scurvy as well, which hopefully we don't see a lot these days. So if we proceed to the palate, hard or soft, the most common swelling is a palatal abscess, followed by, again, fibroepithelial polyp, which usually is called the lip fibroma when it's located there, followed by exostosis, which from all the things that we've mentioned so far, it's a bony protrusion, so hard tissue rather than soft tissue mass, okay? Followed by papillary hyperplasia of the palate, salivary gland tumors, Kaposi's sarcoma, nasopalatine duct cyst, and all the rest are much, much more rare. About salivary gland tumors, okay, so as you can see, when you see a mass on the palate, it's not the highest chances that it's a minor salivary gland tumor, but bear in mind that of minor salivary gland tumors, the most favorable site in the mouth is the hard palate, okay, or the palate. So floor of the mouth swellings, ranula, which is a mucosal in principle, cyaloliths, squamous cell carcinoma, lymphoepithelial cyst or branchial cyst, epidermoid or dermoid cyst, salivary gland tumors again, and mesenchymal tumors are the most common entities. And then if we see multiple swellings in the mouth, there are a few conditions that can present like that. All of them are quite rare, okay? So papillary hyperplasia of the palate, followed by Kaposi's sarcoma, followed by neurofibromatosis. It's usually neurofibromatosis type 1 that presents with intraoral lesions. And it could be mass, and usually that has some skin lesions following that as well. Followed by focal epithelial hyperplasia, which looks like multiple squamous cell papillomas, basically. So multiple warts in the mouth, to put it simply. amyloidosis, granulomatous diseases, and MEN2B syndrome. So if now neck mass, by far the most common reason for a neck swelling is reactive lymphadenopathy, either to an infection or to a malignancy. For whatever reason, that's by far the most common reason to for a neck mass. Epidermoid cyst, thyroid gland enlargement, lipomas, infectious mononucleosis, metastatic carcinomas, and lymphomas are more or less around the same statistical numbers, and then all the rest are very, very rare conditions. Summary, as I said, swellings is the biggest category for differential diagnosis, but from what you've heard so far, the word that you've heard being repeated, epithelial polyp, okay? So by far the most common swelling, if it's not of dental origin, to say that, is a fibroepithelial polyp, okay? Do never forget that if you see a swelling in the mouth, you first of all, unless it's on the buccal mucosa very far away, no teeth present, you first of all have to consider whether it is related to a tooth or not, okay? And you have your x-ray there. You can take an x-ray, you can see whether this is related to a dental condition. You have your vitality test, you have your clinical examination of the dental tissues as well. So bear that in mind, okay? But if we look at soft tissues, fibroepithelial polyp, usually followed by epulis, different types of epulises and pyogenic granuloma, and mucocele, they are about the same statistically, followed by squamous cell carcinoma, salivary gland tumors, cysts, again, not related to teeth necessarily, Kaposi sarcoma, and other tumors like hemangiomas, lipomas, and things like that. So if you want to keep something short in mind, keep this table for differential diagnosis of swelling. And again, never forget to mention dental, possible dental origin. We'll go ahead to change of color. As we've mentioned before, we have white, red, blue, purple, brown, gray, and black. The yellow is very, very rare and is usually can be included under the white, okay? We can have combinations of those. The most prominent combination or usual combination is white and red, okay? And it's the most alarming combination usually. So for the red lesion, I've also broken them down to two categories. The second category is what I call the hematology category, okay? So petechia, ecchymosis, and telangiectasias basically have something to do with bleeding spots presenting in the mouth, and you will see the breakdown of those a little bit later. So if we start with white, okay? White lesions. As I said, four-dye spots, for example, they have a slightly yellowish golden color, but they could be included under the white category. So a generic and quick differential diagnosis of white lesions would be infection and mainly candidosis. And we have to think of all different types of candidosis that can present as white, like pseudomembranous and chronic hyperplastic. It can be reactive, like frictional keratosis or keratosis in reaction to injury, either thermal or chemical, burns basically. We can have other reasons like leukodema or white-coated tongue or hairy leukoplakia. So leukodema is associated with race, hairy leukoplakia is associated with HIV. Genetic reasons like white sponge nevus and other dyskeratotic syndromes. It can be immune-mediated diseases like oral lichen planus, oral lichenoid reaction, lupus erythematosus, and graft versus host disease. And of course, to never forget, it can be leukoplakia. And when we suspect leukoplakia, we always need to exclude dysplasia or possible malignancy. So if we do a detailed differential diagnosis and we see white lesions that we can actually scrape off, by far the most common one is the white-coated tongue, which is a quite common condition. Some of you, like if you go in the mirror, put your tongue out, sometimes you can find that there is a little bit of a white coating in there, quite common amongst patients. They just need to be advised to brush it a little bit, and that is all. It's quite a benign condition. And then, of course, the next most common is candidosis or candidiasis, whatever you want to call it. The detaching one being the pseudomembranous, usually acute. Chronic pseudomembranous candidiasis is more rare, and it usually appears in immunocompromised patients. Morsicatio, which is cheek chewing, and it's different to the linea alba, okay, because it is detaching. So don't confuse the two. Linea alba, which is frictional keratosis as a line on the cheek, cannot be detached, all right? But people that have the habit of chewing their cheeks, it's like, it appears like a flaky mucosa, okay? So thermal, mechanical, and chemical burn, you can usually peel off the white slough off the top. It can also be a reaction to toothpaste or mouthwash, so more like a contact stomatitis. Secondary syphilis can present as a detaching white lesion and infection with diphtheria, but that's quite rare and in only particular areas of the world. So white lesions that are non-detaching, as you can see, there are much more of those on this slide. So linea alba, which is the frictional keratosis, leukemia, leukoplakia, actinic cheilitis, lichen planus, morsicatio. It can be non-detaching as well, just to confuse us a bit more. White-coated tongue, that can be non-detaching as well. Snuff dipping, which is due to the use of smokeless tobacco. I have an asterisk there. The reason why is snuff dipping in some countries is quite common. USA and Scandinavian countries have quite a lot of people do use smokeless tobacco, and in that case, snuff dipping statistically would be probably right next to leukoplakia. Okay. Nicotine stomatitis can appear as just a white lesion, four-dye spots, as we said, maybe white yellowish. And then we have all these other conditions: hairy leukoplakia, chronic hyperplastic candidosis, lupus erythematosus, submucous fibrosis, white sponge nevus, hereditary benign intraepithelial dyskeratosis, pachyonychia congenita, dyskeratosis congenita, tertiary syphilis in the form of syphilitic glossitis, and uremic stomatitis can present as non-detaching white lesions, but much more rare. The combination of white and red, again, that is a little bit more limited than the white non-detaching. By far, the most common is erythema migrans, so geographic tongue, basically. Sometimes geographic tongue it's not always limited to the tongue, so sometimes it can even affect the rest of the mucosa, but quite rarely. Candidosis, so you can have candida that appears as a mixture of white and red lesions, as especially with pseudomembranous, they sit on an erythematous base, and if you remove them, you see that redness of the mucosa. Sometimes it even bleeds, okay? Certain types of lichen planus, erosive or atrophic or ulcerative type. Burns can be white and red, actinic cheilitis, nicotine stomatitis. So if the orifices of the minor salivary glands are quite prominent, that would appear as a white and red rather than just as a white lesion. Erythroleukoplakia, reaction to cinnamon, again, a contact stomatitis, lupus erythematosus, scarlet fever, and verruciform xanthoma. Scarlet fever very characteristically on the tongue, so the tongue has a white coating and it looks like it has red spots on. As you see, there is a slight overlap of certain conditions that can appear in many different ways, okay? Do not let that scare you. Actually, that's a bit easier to remember, because if you remember that it applies into more than one, it's easier to give more conditions in your, name more conditions in your differential diagnosis. So if we see red lesions now, pharyngitis is usually the most common reason. If we examine the far back of the mouth, if we exclude that, then we have traumatic erythema, so redness in the mouth basically because of trauma. Denture stomatitis, which is a candidal infection. Erythematous candidosis that is not associated with a denture. It presents on the palate again, exact same way. It's just that the person is not a denture wearer. Erythema migrans, angular cheilitis, thermal burns, erythroplakia, and of course anemia. that can present with a glossitis, so the tongue can be quite red and shiny. Hemangioma, lupus erythematosus, scarlet fever, plasma cell gingivitis, and radiation mucositis can present as red lesions. Now we focus on red lesions that are specific to hematology. So petechiae, ecchymosis, and telangiectasias. Ecchymosis is a bruise, okay? Petechiae are tiny, small bleeding spots, and telangiectasias are dilation of vessels, of the end of the vessels, basically, put it simplistically. The most common reason for them is non-specific trauma. It can be upper respiratory tract infection, and also some other conditions can present with these red lesions, like infectious mononucleosis, idiopathic thrombocytopenic purpura, hemophilia, leukemia, hereditary hemorrhagic telangiectasia, which is otherwise called Osler-Weber-Rendu syndrome, and CREST syndrome, which is the limited cutaneous form of systemic sclerosis, and CREST is an acronym for, I think it's calcinosis, Raynaud's phenomenon, esophageal dysmobility, sclerodactyly, and T stands for telangiectasia. Varicosities, usually at the ventral surface of the tongue, the most common reason for a blue and purple lesion. Submucosal hemorrhage, so a bruise again. Amalgam tattoo, mucocele eruption cysts, giant cell epulis, hemangioma, granular Kaposi sarcoma, and then more rare conditions like nasopalatin duct cysts, salivary gland tumors. Remember when we mentioned that mucoepidermoid carcinoma can very much look like a mucocele? It's because it can sometimes have that bluish, purplish tint to it. Gingival cyst of the adult, blue nevus, and malignant melanoma. Brown, gray, and black. So racial pigmentation, okay, the most common reason, followed by amalgam tattoo and black and brown hairy tongue. Melanotic macule, which is practically a freckle. So what we call a freckle on the skin is called a melanotic macule in the mouth. Smoker's melanosis, non-amalgam tattoo, melanocytic nevus, malignant melanoma, never ever, I've underlined it there. So when you have a pigmented lesion, you have to include malignant melanoma in your differential diagnosis always. It can also be drug-induced. The most common drugs are contraceptives, especially minocycline, and chloroquine, which is very popular now with COVID because it has been used in the treatment of COVID, can cause drug-induced pigmentation in the mouth. Oral melanoacanthoma, heavy metal poisoning, Poyes-Jaeger syndrome, Addison's disease, neurofibromatosis type 1 again, maculae melanotic neuroectodermal tumor of infancy can also present as brown, gray, or black lesions in the mouth, but they're very, very rare. So moving forward now to patient management. What do you need to do? First of all, you need to have the general management of the patient. We have to look at the overall health of the patient. We have to look at their lifestyle choices, whether they need a smoking cessation, counseling or support for mental health issues, alcohol consumption support, diet support. Always enhance oral hygiene, and always look at the general approach to the patient from a preventative point of view. So let's say you have a patient that is to undergo a procedure, you have to be proactive and anticipate whether that procedure is going to cause them any more trouble and act preventatively to whatever more trouble that might cause. Let's say they can get prescribed a drug that can cause them dry mouth, or they can have radiation or anything like that. Then also we have the approach which is specific to the condition. So further investigations, what they might be. Medical imaging, any type of medical imaging. We have our radiographs, PAs or OPTs or whatever, CT scans, MRI scans, ultrasonic scans, all sorts of, you can have scintigraphy, you can have a scintigraphy of the bone, you can have radioactive medical imaging for the thyroid, for example, whatever it need be. Blood analysis. So the most common checks that we do are full blood count, hematinics, liver, renal function, and what we mostly do in oral med is also specific antibodies for certain conditions. We do celiac disease screening, and any other blood test that we might need, we can ask for. Microorganism detection testing, like we take swabs to do cultures, to do PCRs like we do with COVID. Swabs usually are used for Candida, or if we have a specific bacterial infection and we need to see what type of bacteria we have and what antibiotic is best to use, we can do a culture and then an antibiogram. Tissue specimen analysis, which can be cytology or histopathology. So we can have a smear where we take some, like a few cells of the tissue and we put them under the microscope with different types of stains, or a proper biopsy, and with all the different counterparts. You can have an incisional, an excisional, you can have a punch, you can have a fine needle aspiration biopsy, whatever needs to be done. We have other kinds of tests like cyanometry or Schirmer's test. Drug prescribing, so whether we need to prescribe any local or systemic agents specific to the condition that we're dealing with. And of course, the management of the patient does include referrals for specialist advice or referrals for biopsy or to specialist clinics, as long as they are needed or appropriate. Or even if you go through NICE guidelines, you will see that in quite a lot of conditions, they do say if you're not certain of the diagnosis, you are advised to refer. So if you're not certain for what you're looking at, please feel free to refer. Depending on where you will be, you can refer either to an oral medicine clinic or to oral surgery. Educating the patient is also an important part of the approach. So especially if people present with chronic conditions or recurrent conditions, they need to know what it is that they have. Let's say someone presents with oral lichen planus. They need to know that they have to live the rest of their lives with this disease, okay? But they need to be reassured that we can help them deal with the symptoms of the disease. Let's say they have an ulcerative type and they're in pain, we can help them deal with that, okay? And of course, again, prevention comes into effect. As I said, if you have a patient that has been diagnosed with an oral cancer and they are about to have radiotherapy following their resection of the cancer, you have to follow certain preventative measures from extraction of teeth that might pose a risk for extraction post radiotherapy, or prepare the patient for the possible mouth that they will have to deal with. Okay. Guidelines and further reading online. So NICE and SDCEP have quite a lot of information. NHS, AZ, and then BDJ are very good sources. So if you follow these links, you can find a lot of information regarding many of the conditions that appear in health. Further reading. So as I said, with every dental school has a favorite or reading suggestions. So follow what your school has suggested at the oral medicine curriculum. So for example, I think these are 5 of the most common books that are suggested as core reading amongst different dental schools in the UK. If I forgot anything, please forgive me. As I said, I teach in Manchester. I was taught myself, I was trained with having Professor Kelly, because obviously his reputation was way outside the borders of the United Kingdom, from the UK, and then different professors from the USA. So I've just picked the ones that I think they're really, really good books. Pick one, you don't have to read them all, okay? Just pick one and follow your school's oral med curriculum to help you. So if we move on to the scenario, we had a 52-year male. Just to say, I've just put the scenario together based on a patient, but it's not a specific patient. So I find a few things just to have things to discuss, okay? The patient complained of a white patch on the buccal mucosa on the left-hand side. His medical history is that of high blood pressure, non-insulin dependent diabetes mellitus, and high cholesterol. He takes atenolol, metformin, and simvastatin. His mother also had diabetes type 2, and he is an ex-smoker that only quit 2 years ago, and he consumes 12 units of alcohol a week. He's a high school teacher, so sometimes that can be highly stressful job. It depends on what position you have and how you deal with things in life. He is a non-regular dental attendant. Last week, his GP was 1 year ago to replace a lost filling, but he does brush twice a day using an electric toothbrush and a fluoride toothpaste. So proceeding with examination, we have good facial symmetry, no sign of limited mouth opening, clicking on the right-hand side DMJ with no other symptoms, no lymphadenopathy, no discontinued muscles of mastication. And we find a white patch on the buccal mucosa left-hand side behind the commissure at the occlusal level, 2.5 centimeters long, that cannot be wiped off. The patient presents with a similar, smaller and less lesion on the right-hand side as well. So as I said before, quite a lot of the information is already being given to you, okay? So half of the questions to get a pass, you have it right there. You don't need to look further, okay? So if we see the photos of clinical examination, has anyone picked up anything weird about these two photos that doesn't fit the description, basically? So both photos are photos of a different patient, okay? I've put them there to make the case, but how can you tell? Can you see the mucosa there, the color of the mucosa? Okay, you can argue that the color is based on how the light goes, but can you see the pigmentation there? That is probably racial pigmentation that actually is not present there, okay? So if someone is really observative, you could see that these were two different. I didn't do that to trick you, okay? I didn't see it when I picked them. I saw it later. So if you're really observative and you see what's in front of you, you can, pick things around. So what are the discussion points? As I said, the chances are that these discussion points, this is what we usually ask in Vivas in Manchester, but that is what all oral med will look for. Describe the lesion, give a differential diagnosis, give a most likely diagnosis, consider if any features could suggest this lesion to be sinister in nature, and how would you manage the patient. In Manchester, in addition to that, you will have an extra question, which usually, I think, is oral surgery. It applies to a medical emergency, which obviously it doesn't, it goes beyond the purpose of this presentation, so I didn't include that. Again, to remind you, exam skill set being tested, recalling information, knowledge, understanding, and clinical reasoning. So, use the information given to you. I've copied and pasted. All with color red are that would give a pass. So a pass score, you have to state that it is a white patch or a white plaque or a white lesion on the buccal mucosa, left-hand side, behind the commissure at the occlusal level, 2.5 centimeters long, and that there is a similar lesion on the other side, okay? That will give you a pass. So you need to state what type of lesion you have, 1, where is it located, very important, and 3, if you can give either a size or a shape or both, that will guarantee you a pass. If then we're looking into getting a bit better scores in this, then you can say that there are no accompanying symptoms reported, so there is no lymphadenopathy. The lesion cannot be wiped off. Obviously, this is quite important to help you do a differential diagnosis and then a most likely diagnosis. And that the lesion on the right side is smaller, less prominent. So the lesion is bilateral, but it's not exactly symmetrical, okay? That's what that implies. If we go further than that, you can add details but what you see in the photo. All right, so I've repeated the first two, and then as I said before, no other findings extraorally, so we didn't have any skin problem on the face. Pigmentation at the margin of the lesion on the right hand side. The surface is not smooth. The anterior third of the buccal mucosa is affected in both sides. The patient has not complained of pain. You can add there that the lesions look, especially the right hand side, roughly triangular, if you like. So any more details that you can give will work on your benefit. So green will take you to distinction. To get the distinction, you have to say all the red, almost all the purple, and most of the green, okay? So that's why I've done that to all the rest of the slides. So it's color-coded to help you know, to kind of guide your revision to what your target, what your goal is for your finals. So differential diagnosis, name and justify. This is your chance to shine, okay? So as we said before, I use the simple differential diagnosis here. If you wish to add more, fine. You need to name 3 different conditions to get a pass. If you just name 3, you will get a pass. So if you say it's probably candidiasis, it can be candidosis, a white lesion, it can be frictional keratosis, or you can say injury, and it can be leukoplakia. These are 3. These will get you a pass, okay? Leukoplakia needs to be included. Candidosis needs to be included because they are the 2 main conditions that we have to differential diagnose between. Okay, so these 2 need to be mentioned. From the other ones, you can mention whatever. The more you mention, the higher your score. Okay. So you got your pass, you've mentioned, let's say 5 or 6 conditions, and you got your honors, but you really want that distinction. So the distinction you will get in by knowledge and clinical reasoning. So what would be that? So you can say it could be candidosis, but as it cannot be wiped off, it could be the type of candidosis called chronic hyperplastic candidosis, which the usual location is behind the commissure. You can give more details, so you give more details. You don't have to exhaust the list, okay? I've just placed there, like, this is not an exhaustive list of what you can say. I've just giving you an example on what to follow for your answers. So frictional keratosis, the patient doesn't present with parafunction, but clicking sound present, though asymptomatic. The lesion is at the occlusal plane, so one could argue that differential diagnosis as well. Injury, it could be a thermal or a chemical burn to present white, but there is no reference to an incident prior to the appearance of the lesion. So this is probably a most likely less likely, diagnosis. Leukoplakia, give the definition of leukoplakia, is a white plaque that cannot be otherwise determined. Very, very important to exclude dysplasia. And in this case, you can argue that the patient presents with risk factors. He is an ex-smoker. He only has quit for 2 years and he's smoked for many, many years. And as a rule of thumb, to kind of get away from the effect of smoking from your body, you need to be smoke-free for as many years as you smoked, okay? And almost borderline alcohol consumption. So we know that the line for alcohol consumption is 14 units a week. But mind you, if you have like a small stature person, 12 units would probably be flirting with that border, okay? Leukedema is usually more diffuse and less well-defined. It usually covers a bigger area. It's more common at patients with darker skin. Hairy leukoplakia associated with HIV, usually lateral border of tongue, usually middle to posterior third where it appears, so less likely for this lesion to be hairy leukoplakia. White sponge nevus, its onset is on childhood as it is a genetic, a hereditary disease. Other dyskeratosis syndromes, again, onset is on childhood, so the chances are that this cannot be them. And also there are other areas of the body, especially the skin and the nails, that are affected. Oral lichen planus. Oral lichen planus can be argued again in this differential diagnosis by the bilateral presentation. You can refer to the different types of oral lichen planus, the most common one being the reticular pattern, but we do have a plaque-like type of oral lichen planus. We might have possible skin lesions, specifics of the rash, so where you usually find it or how does it look. Mention the lichenoid reaction, especially in relation to the patient's medication. Patients take metformin and atenolol, especially metformin, but atenolol as well, can cause lichenoid reaction in the mouth. And with lupus, we usually have skin lesions. The intraoral lesions might also present as red or combination of white and red. And then if you know graft versus host disease and what it is and give a definition, that will definitely give you extra points. Graft versus host disease, to explain it simply, when you have a transplant in a host, so in a body, a solid organ transplant, the immediate reaction of the body is to recognize it as foreign and try and attack to destroy it with its immune response, with its immune system. With graft versus host disease, it usually appears to patients that had bone marrow transplant. And what happens is that instead of the host attacking the transplant create its own immune response against the host. So it produces antibodies against certain types of cells of the host, and the host can present in the mouth exactly as oral lichen planus. So the more you elaborate, as I said, this is not an exhaustive list. You don't have to mention all of this, but if you choose to include like 4, 5, 6 conditions in your differential diagnosis, and you give reasoning behind why you think this is likely or why you think it's unlikely, okay, that will give you the higher scores. So when we approach most likely diagnosis, we need to name it, we need to justify it, and we need to discuss it, okay? So in this case, the most likely diagnosis is chronic hyperplastic candidosis. Extra points you would get by mentioning candida leukoplakia, which is a term that used to be used in the same way, but some oral med specialists now use them separately. Some still use them the same. Some use only the chronic hyperplastic candidosis and not at all the candida leukoplakia. If you discuss the controversial nature of the lesion, so it is a lesion that is very much debated in the oral med world about, okay? So quite a lot of the researchers argue that this is a proper candidal infection, and what we see is a reaction of the tissues to the infection, but quite a lot of researchers support that no, it's a leukoplakia that has been secondarily infiltrated by candida, okay? So what we usually find is that the candida hyphae invade the parakeratin layer, but never penetrate deeper into the prickle cell layer. So any additional histology details that depends again on what university you are and how much histology you do, you can to a lot. That is your choice. The more you give, the higher your scores. You can, at this point, discuss generally candidal infections, give an understanding and show that you understand that candida is a commensal organism, so it gives you opportunistic infections. You can say that the most common species is Candida albicans, but we have others like Candida glabrata, Candida tropicalis that can also, others that can also cause infection in the mouth. It is present to up, according to NICE, that number, that 45% of healthy patients or healthy individuals, that is according to NICE guidelines. You can also discuss the main candidal infection presentations, which is pseudomembranous, acute or chronic, erythematous, acute or chronic, and hyperplastic, which is usually chronic, okay? And that the fact that the hyperplastic is the least common of the three. If you want to give the additional conditions that relate to candida, like median rhomboid glossitis, angular cheilitis, please feel free to do so. And then if you want to generally give a general description of chronic hyperplastic candidosis, So it comes in two forms. If you know the one form, which you can call it either homogeneous or plaque-like, either way, that will give you a pass. You have to know that it doesn't detach, or that it detaches really, really difficulty. But then if you can mention that there is another form, that it can appear in a nodular or speckled form, that will give you extra points. It is usually bilateral, on the buccal mucosa, just behind the commissure. Less common areas that it can present at is posterior, so the rest of the buccal mucosa, tongue and palate. That will, score you higher points, as it's not very commonly known. And then you can give a specific reasoning why you think this particular lesions that we saw on the photos are the chronic hyperplastic candidosis. So it's a white lesion that cannot be wiped off. It is bilateral. It is located behind the commissure. It is roughly triangular. There is no reticular pattern present, though oral lichenoid plainness can be plaque-like, and oral lichenoid reaction can be argued. Higher prevalence in middle-aged men who are smokers, okay? Here you can also discuss risk and predisposing factors. So if they are the ones that you know, like smoking, broad spectrum antibiotics, and inhaled oral corticosteroids. These are the basics. And then if you want to go a bit deeper, diabetes, immunocompromise, poor oral hygiene, and then even deeper, local trauma, malnutrition, and hematinic deficiencies. Specifically to chronic hyperplastic candidosis, and to this case, the predisposing factors are smoking, possible hematinic deficiency, and then the diabetes can also be argued as well. So as I said, this is not an exhaustive list. You choose how you want to do the discussion. You don't have to mention everything I've put in here, but you have to kind of follow it as a rough guideline on what you can discuss. So sinister features, again, name and justify. So there is a possible risk for malignant transformation. You have to know that, okay? And usually that is the persistence of the lesion. So if the lesion is still present after treatment, or for a specific amount of time that is quite long, usually that applies to all types of lesions. That might be a sign that there might be something sinister going on. Refer to relevant guidelines, and also discuss mixture of white and red, possible change to the worse whilst in treatment, and the case of speckled leukoplakia, okay? Moving to management. As we said, we are trying to do a holistic approach. You can take a swab to confirm the presence of candida. You can mention that as a further investigation. Bear in mind that swabs, especially for chronic hyperplastic, are of questionable value, but you can say that and mention the questionable value. It will definitely give you extra points. You need to know that there is some kind of antifungal treatment needed. And then if you elaborate on that, so we have topical and systemic antifungals, and then mention the different types and what is first choice according to guidelines. So we have the main topicals are miconazole gel, which is the first choice of the topicals. And then the other one that we usually use as a topical is nystatin oral suspension. They're just the two, okay? And systemically, we usually use fluconazole. So if you mention that we have these choices, and depending on the clinical guidelines, we usually start, if it's like a mild lesion, we can start with only topical. If it's more severe, we usually give a topical, a combination of topical and systemic. Most cases, we really need to give systemic for chronic hyperplastic to resolve, okay? So the first choice topical is the miconazole gel, but always remember there might be contraindications, like the most common one, if the patient is on warfarin, you might need to think of an alternative, and that would be then the nystatin. Referral to specialist clinic, that is also part of the management. You have to state the reasons why, if you think there is a need of a referral straight away. If you think that we can try and deal with it at a general dental practice level, but then if the lesion persists, or if the patient is severely immunocompromised, then we might think of a referral. Doesn't it need to be urgent? Again, follow guidelines and trust your clinical judgment. As I said, like if you have a person that is severely immunocompromised, I would, you need to refer them because they probably need treatment. They probably need to be hospitalized for treatment. Biopsy to exclude dysplasia. As we said, it is a potentially malignant lesion, if and when needed. So you can here again mention, if you haven't done before, different types of biopsy. So give details of preferable location if possible and follow guidelines. So in this case, it would be an incisional biopsy. Okay, thus you can mention that and explain that ideally it should be taken by including part of normal tissue, and if there are any red lesions, include those as well. Eliminate possible predisposing factors like smoking cessation. The patient has already quit smoking in this case, but you can ask whether there was any relapse. Let's say 2 months ago he smoked like 2 cigarettes or anything like that, and offer a smoking cessation. Ask for additional investigations like blood tests to exclude a hematinic deficiency. Educate the patient regarding his condition and empower him to make an informed decision, and kind of you're helping him by giving him his options and his choices to choose what suits him best to deal with his condition. Do not forget, the patient has come to you, okay? He didn't just come for a general checkup, he came for the particular lesion. So he already taken the most important step towards his treatment. Explain all possible risks and the importance of treatment if you need to review or if you need to do a referral. So basically, treat the patient if you were sitting in the chair, like you had no one else behind, it's just you and the patient, and you need to help them. The more you act like an already qualified dentist, let me put it that way, the more high scores you will have. Guidelines specific to chronic hyperplastic candidosis, most of them are by NICE, okay? I don't know why they don't look activated, but you can copy and paste them in your browser and they will take you to the relevant pages. And general tips, all right? Keep it simple and straightforward, or as I like to say, short and sweet. Be confident. If you're not sure about a question, ask again. Try and keep in mind as much of the information given to you as possible. Just that information can probably give you a pass in quite a few questions. Eat well, sleep well the night before. Do not forget, it is not a life or death situation, though it probably feels this way. And do not forget, you made it this far. You definitely can do this, okay? Thank you very much. There we are. If you excuse me, I'll just turn my lights on because it's gone quite dark.
Same issue.
If anyone's got any questions,
there we are.
Write them in the chat now.
Come to Kings, please.
That was amazing.
I hope I didn't tire you or bored you terribly.
No, I'm definitely not bored. I just need to go revise, I think.
Oh, yeah.
I scared you then. No.
Okay, so
There we go. We've got our first question in. Does dysplasia always indicate malignancy?
Dysplasia doesn't indicate malignancy exactly, but if you have dysplasia, you do need to remove it. If it's mild, sometimes you might choose to just remove the predisposing factors, because in mild cases of dysplasia, the mucosa has the ability to kind of correct them, okay, by itself without extensive surgical approach. But if you have moderate or severe dysplasia, then if you leave that without doing anything, that will definitely develop into malignancy, okay? Even mild dysplasia, if you don't do nothing about it, it will develop eventually in time into malignancy. With severe dysplasia, there is a very fine border between that and actual malignancy. And as I said to all my students, it's the basement membrane. So severe dysplasia to actual invasive cancer, the only difference is that invasive cancer has found one spot and broken that basement membrane. Even one cell, if one cell has gotten outside that basement membrane, you have an invasive cancer. And that's the only difference between the two when they first start. Not the only, the main difference, okay? So mild dysplasia can be dealt with with predisposing factor control, smoking cessation. With smokers, again, I put a big question mark there on whether they can really control. Like, I'm more, as a patient myself, if I had a dysplasia, I would like it out. But of course, it depends on the case. Mild dysplasia can be argued that you can have mild dysplasia with chronic candidal leukoplakia that can be dealt with. So you have the antifungal treatment, and then you have no dysplasia later on if you repeat the biopsy. Okay, so it has been mentioned, for example, in this particular case. But I'm quite, I don't know. I don't feel safe if I just leave a dysplasia there. I wouldn't like one in my mouth. Let's put it that way.
Okay, the next one we got is, what is the difference between non-detaching morsicatio and linea albia?
Morsicatio, non-detaching. Okay, so the way it looks, the linea alba is they're both a type of frictional keratosis. Okay, so linea alba is very distinct. It's a line. So you see the line going like a little wave, white wave. It can start from behind the commissure and extend all the way back to on your mucosa. So it's a line. Morsicatio, on the other hand, chewing chewing the cheek, the inside of the cheek, extends usually in a bigger area, and it looks very much like a flaky white lesion rather than a line. So it's not a line. Okay, that's the main difference between the two. So the one is a line, the one is like little flakes of epithelium, detaching or not detaching, depends.
Okay.
I believe, sorry to interrupt, I believe that morsicatio is a term used more in the USA rather than the UK.
Okay, okay. And then, does chronic hypoplastic candidosis require a biopsy?
Yes, if the lesion, as I said, if you go through the guidelines that I've put there, yes, if the lesion persists for more than 2 weeks after treatment. So you give treatment for 2 weeks with systemic fluconazole. That's the maximum you can give, 50 milligrams of fluconazole per day. And if the lesion has not resolved, then you might consider having biopsy. Again, a big debate. There are certain articles on the BDJ between different people from different universities within the UK arguing whether there is a point to give antifungal treatment before the biopsy or not, okay? But usually what we do is that we see the patient, we give the antifungal, because it has been noted that with just the antifungal, you might have full resolution of the lesion. So in that case, the patient avoids having a biopsy, which is not the nicest experience of all. So yes, that is what we usually adhere to. So antifungal and then biopsy if needed.
Okay. And then the next one we have is, does amalgam fillings always cause a risk factor for lichen planus?
Not always. It depends on the person. So it could be an amalgam filling. It could be a porcelain bonded metal crown. So the metal in there, I have seen lichenoid reactions against a crown rather than an amalgam filling. But in theory, yes, some of the components of the amalgam pose a risk. It always depends on the individual as well. So it is not not a one-way relationship. So if you remember, I quite like my perio, apart from my oral med. So if you remember with perio, you have those, it is called something, forgive me, I'm very bad with names. So you have that gram where you have the 3 cycles, and then you have the overlapping area. So that's what it is as well. So you have the risk factor, which is the amalgam. It could be smoking for cancer, it could be whatever, but then you have the host on the other side, and you might have other extra risk factors. So you need a combination of things to develop a condition, okay? So it doesn't mean that everybody that has an amalgam in their mouth will get a lichenoid reaction. Some people will. If you ask me, I quite like my amalgam fillings. I still have them in my mouth for many, many years, some of them. I don't want to remember how many. I'm an advocate for the amalgam filling. I know it's going to be phased out eventually, but other countries that try to phase it out had to reintroduce it. So I don't know, like, what do you do with the, how many crown lengthenings can one do to do a filling, a composite filling? I don't know, but that's my personal opinion, okay? Nobody else's. So do not be afraid of the amalgam in that way, but yes, it can cause, it's quite rare, so it's not that common, okay?
That's your Venn diagrams coming into play in it.
Yeah, thank you. See?
That's wrong.
I'm bad with any name outside oral med.
There we go. We've got a straightforward one now. Do you know, when would you rather, straightforward one, but I can't read it. How do you know when to do an incisional or excisional biopsy?
Yes, that's a very common question. I get asked this quite a lot of times. Experience helps to start with, but besides that, the main choice is depending usually on the size of the lesion. So if you have a really small lesion, then you can remove it with an excisional biopsy. Okay, make sure that you remove it, you remove the whole of it, and you put it under a microscope and you examine it. But if you have an extensive lesion, or if, let's say, the lesion is at an area where you're going to cause, if you remove all of it, but you're going to cause a lot of trauma, and the lesion, the suspected nature of the lesion is not necessarily sinister, or you don't know if it is or not, it's better to cut off a smaller piece and see it, as long as that covers your diagnosis. So we need to have, it works both ways. So we cannot go too small, we cannot go too large. We have to find the golden standard in between that actually is appropriate for the specific lesion.
Okay, that builds on nicely to our next question. Dan was asking, in the case, you said initially an excisional biopsy instead of an incisional. But
oh, I'm sorry, I've made a mistake then. No, incisional biopsy. If we do a biopsy for this particular case, it would be incisional, not excisional. I might have said, I'm sorry, that was my mistake.
Okay, but would you lose marks if you said biopsy on its own, or would you need to be specific?
You wouldn't lose marks. The more you say, the more marks you get. Okay, you cannot lose marks by saying biopsy. If you're unsure, say what you're certain. So you're certain that, yes, I probably will need a biopsy of this lesion, for example. If you're prompted to say, would you need an incisional or an excisional, then, as I said, size is usually a good judge on whether you will or not. So if you have a quite big lesion, the chances are that it's going to be an incisional biopsy. Smaller lesions, or like if you have a swelling that's pedunculated, so it's a bit easier to remove the whole, that would be excisional.
Okay.
Okay.
And then the next one we had is, can systemic antifungals be given in a general practice, or is that only secondary care?
You know, I wouldn't know that. I would have thought that, yes, you can prescribe them in a general dental practice if you have, you know, what do you do with a chronic hyperplastic? You really need them. If, I think the BNF, I have one, have a look. If you check the BNF, probably it will say. If you're not sure, you can always ask the GP to prescribe.
Okay. The next two we have are our last two, and they're all to do with systemic antifungals. So first,
not my strong suit.
we'll give it a go. So with CHC, would you start with a topical, or would you go straight to systemic antifungals, or how would you decide?
Well, according to NICE guidelines, what you need to do is apply clinical judgment. So if you go to one of the pages I've put there in the end, I actually have the notes of exactly what it says, so I can actually read it out to you. Let me see where they are. So when you decide treatment, NICE guidelines, it says exactly apply your clinical judgment for severity. It states, that's what it states. So what you do, if you have an immunocompetent patient, you start with miconazole gel Okay, that is first choice, as long as you can give it. Miconazole gel can be given from the age of 5 months onwards, as long as the baby is not a preterm baby. Okay, so you can prescribe it to children as well, which makes it quite easy. That's generally for antifungal treatment, because children get oral thrush as well. Okay, whilst fluconazole is contraindicated for the age of under 16. So immunocompetent, you start and it's not severe, so it's not extensive. You're not worried about the patient. The patient in this case stops smoking. You could start with just the topical. I would review in a week rather than in 2, and you will see whether there is slight regression or not. If within a week the lesion is unchanged, you may consider giving a combo of topical and systemic. If you see a regression, you continue for another week and see how it goes. No more than 2 weeks. Then you can introduce the systemic, okay? And then again, you give for 1 week, you review, and then if need be, you give for another week, no more than 2 weeks. If the lesion has not gone down with systemic after 2 weeks, okay, then it needs biopsy, referral, whatever you decide to do, depends on where you are, depends on what your competencies are, depends on what you feel comfortable with, okay? If, on the other hand, you have a really severe case, immunocompromised patient, HIV patient, or a transplant patient, or whatever immunosuppression, we have a lot of people having diseases that fall under the rheumatology department that take immunosuppressive drugs, so in high doses, so they can present with candidal infections. So for those, you have to give systemic from the beginning. And in some cases, in severe immunocompromised, urgent referral from the start. You can start the systemic, but they have to be hospitalized, and you have to seek specialist advice.
Okay. So then we're down to our final 2. So if fluconazole is contraindicated, what other systemic antifungal options do you have?
As a dentist, I don't think you have much more. Okay. If fluconazole is contraindicated, you refer further, maybe in a hospital. And for someone to need fluconazole, you can try the topical first, okay? Again, if it's not severe, if the person is immunocompromised, for example, you cannot prescribe fluconazole to anyone below the age of 16, okay? Then you need to seek specialist advice. So it has to be, for example, go to a pediatrics clinic for them to decide what kind of systemic antifungal they will give. In severe immunocompromised patients, they even give intravenous or injections rather than tablets.
Okay. And then last but not least, do you refer oral leukopenia, OLP, or do you wait 2 weeks? I know I'm struggling here.
Oral lichen planus, okay. Oral lichen planus, if you have, if you're sure that it is oral lichen planus, so you have the typical reticular pattern, no ulcerative lesions. Pro-COVID, we usually did a biopsy to all of them, especially erosive and atrophic types. So we always need a biopsy for those types. But the reticular pattern, you just keep it under review. You don't necessarily, if you're confident that you can deal with it, okay, you can just keep it under review, because if it's just a reticular pattern, there's always possibility to change, okay? So if someone, like if a woman in 40s like myself presents with oral lichen planus reticular pattern, it doesn't mean that in 10 years time it cannot be an erosive type, okay? But you keep it under review. But if you wish to refer, generally refer for any reason. We have referrals in the oral med clinic of facial pigmentation. And rightly so, if you ask me. If you're not sure of what, and that applies to everything on NICE guidelines. If you're not confident on what the lesion, what the condition is, or if you're not confident on how to deal with this condition, no second thoughts there, refer.
Okay. I think that's a nice time to leave it off. If unsure, refer. I'm sure all of us will hit our oral med notes now, and we'll have no referrals unless they're urgent. So once again, Dr. Elleni, thanks very much for giving up your Thursday evening. Really, really appreciate it. Thanks for
Thank you for having me. I really enjoyed this.